Okay, everybody, this is a quick overview of maternal early warning signs. I know that we've discussed this and you've received emails, but we're going to drive it home for the skills fair. So the purpose of MEWS is to facilitate timely recognition, diagnosis, and treatment for pregnant and postpartum women to avoid maternal morbidity and mortality, aka trying to prevent maternal death in America that we see on the news. So this prompts the nurse to reevaluate a MEWS trigger and then escalate as necessary. The policy is that when you recognize a MEWS trigger, it should be validated within 20 minutes. So that means that if you see a MEWS trigger, you have to reassess it in 20 minutes. Otherwise, you can't act on it. If the trigger persists, the nurse will contact the provider, whether that be anesthesia or the OB provider, and request action. So urgent action means the provider should be at bedside within 30 minutes or have some type of order to act on within 30 minutes. So this doesn't necessarily count for the labetalol protocol for your hypertension because we have a process in place for that. But we need to be looking at those pressures that drop down below 90 or 40, except for within 30 minutes of an epidural, and have those reevaluated. So our 86/50 needs to be rechecked within 20 minutes and have something done about it, or be moved up the chain to the provider so that the provider knows. Heart rate. This one is often left behind a lot. We have a lot of patients who have heart rates greater than 120 who do not have another reevaluation within 20 minutes. You don't reevaluate, you can't act on it. So make sure heart rate less than 50 or greater than 120 that it's being rechecked within 20 minutes. And if it continues to be elevated, or if it continues to be lower than 50 in that case, then you want to let that provider know that you have a MEWS trigger, even if it's sending them a text saying, hey, her heart rate's 130 and it's staying 130. They may give you an order that says, continue to watch it for an hour and let me know if it doesn't get better. Or they may have some type of order for medication, whatever it may be, or tell you to go assess something different. Document that conversation and do whatever they say. If the heart rate or the MEWS trigger continues to persist and you feel like you're not being taken seriously or that your concerns aren't being met, that's when you can move up the chain. So respiratory rate less than 10 or greater than 30 as well. And oxygen saturation of less than 95. Again, this is something that often we see, but we don't reevaluate. So take note, though, of those O2 sats that come across when your patient's sitting up for an epidural, or if the monitor is, not connecting good. Sometimes it'll read 77 or 83, and you know that's not right because you're looking straight at your patient and she's got great perfusion. You can delete that. That's the reason we have a data validate button, is you do not have to validate all of her vitals and then make a note. You can do that if you want to, but that's extra charting. You can simply delete a vital if you do not believe that it's real with good clinical knowledge, like her being not blue. And then oliguria, this is one that you can't recheck in 20 minutes. It would be over 2 hours, but if they have less than 35 on their output, then that's something you want to notify the provider, get an order, or have them come evaluate. Immediate action is more of an ASAP, and this is when these criteria are met and they do not have to persist for 20 minutes. You have a mom who's suddenly confused or suddenly agitated or combative or unresponsive, or if the patient is hypertensive, triggering the labetalol protocol while reporting a non-remitting headache and shortness of breath, because you're looking at a potential stroke. So if an immediate action is required, get the provider to the bedside immediately within 15 minutes. Have those notification and at bedside times documented clearly in the chart. And then use anesthesia if you know your OB provider can't get there in an appropriate amount of time. and use the anesthesia personnel until OB can get there. Bedside evaluations could be simply orders for diagnostic or therapeutic interventions, a plan for a frequency of monitoring, like I mentioned earlier, or reevaluation, and criteria orders for further provider notification. If MEWS conditions persist after corrective measures are taken, continuously and nothing's helping, that's when you could look at considering a consult by an intensivist or a maternal fetal medicine by telemedicine availabilities. We do have a direct line to both sets of MFMs for both sets of practices. Additionally, if you have rapid deterioration, don't forget we have a rapid response and code team that can be called. If you are calling your provider and you want to suggest certain types of orders based off of the different signs that your patient or MEWS triggers that your patient's exhibiting, these are all just little suggestions down here that you could suggest whenever calling the provider. And if the nurse and the charge nurse questions any aspect of the patient's care, or if they feel their needs aren't being met with their MEWS escalation, the issue's not being resolved, then we can go up the nursing chain of command, as I mentioned. Call Angie, call Tana, call myself, house supervisor, and then we may even have to get our CNO or CNE notified as well, because our number one priority is not to not hurt feelings or to know that because it was okay in the past, it will be okay this time. Our top priority is to escalate these concerns and get them fixed and provide the best care that we can for our patients. So let me know if you have any questions, and thank you.